Thank you very much. So we're going to change pace a little bit here and talk a bit more about something more philosophical rather than technical, about why we fix fractures of the clavicle and how we got to where we are today. Because when I was in orthopedics as a resident, in 5 years of a fairly busy residency, I never fixed a clavicle fracture. Whereas now it's one of the commonest things we do. So how did we have such a wholesale change from a fracture we never used to fix to a fracture that we routinely fix now? And that's what I'm going to talk about in the next 15 minutes or so. Disclosures haven't changed. I also want to make it clear for this talk that this is the kind of fracture I'm speaking about, a completely displaced fracture of the midshaft of the clavicle in a relatively healthy and active person. So all of the things I'll talk about and all the papers I describe pertain to this specific kind of fracture, completely displaced midshaft fractures. Our thinking on this topic was dominated for years by two major papers that came out of North America in the 60s that talked about a very good success rate with non-operative treatment. These papers said the non-union rate was 1 in 1,000 or less, that all of these fractures healed, the patients always did well, so we should leave them all alone. And those papers dominated the conventional thinking for decades. The outcome was described as generally good. All of these fractures heal. You never get a non-union. Malunions don't matter at all, and you can leave them alone. So operating the clavicle was a bad idea. And really, that was 1980s, 1990s. And we hadn't really changed much since the 17th century when Paul Vigina said, with fractures of the clavicle, you could treat them almost any way you wanted. You could put on olive oil, you could put on pigeon dung, and it really didn't make any difference whatsoever. So in 1990, really, this is kind of where we're at with treatment of these fractures. It hadn't changed in a long time. I would argue that we could do better than that. This is a patient of mine who had a bad clavicle fracture as part of a polytraumatic event. He broke his femur and his pelvis, which we fixed. When he woke up, he said, "I feel great, doc, thank you, but why didn't you fix my clavicle fracture?" And I said to him, "Well, we don't need to fix it because they all heal." And this is him about a year later. You can see it hasn't healed. And he has a typical deformity with a clavicle fracture of inferior displacement and medialization of the clavicle. And this is his radiograph here. So I thought to myself, if we took this patient in the operating room and fixed every other displaced fracture he had, why wouldn't we fix his clavicle fracture? This is another patient who was told had a badly displaced fracture, and she was told by her surgeon that she should not have anything done because it would leave her with a bad scar, and cosmetically it would look very poor. And you can tell by the look on her face, she's not happy with how things turned out with non-operative treatment either. She has quite a disfigurement, she has asymmetric shoulders, and she ended up with a painful non-union. So these cases I was seeing over and over again in my practice. And what we're looking at in these radiographs are simple things like shortening and inferior displacement. But this is actually a complex three-dimensional deformity that results from the non-operative treatment of these fractures in many cases. This is a patient of mine who drew his own self-portrait saying, "My shoulders also rotated forward." He was an engineer, and he was showing me this rotation occurs as well of approximately 30 degrees in him. And he said that was a major problem for him. It's such that his shoulder blade or scapula winged or kicked out at the back because the shoulder goes with the distal fragment in a clavicle fracture. And it can roll forward and have this kind of winging pattern that you can see in these pictures here of patients who have symptomatic clavicular non-union after fracture. You can see the obvious winging of their scapulae. So we know that it's a complex three-dimensional deformity that also occurs with these injuries. And I was seeing more and more patients like this in the late 90s in my referral practice who said, "I'm not happy with my clavicle," and I didn't understand why, because I was taught these all heal and do fine. Lynn Crosby's group finally published a paper in 1999. This was the first paper that looked at clavicle fracture outcome as the patient described it. So he used patient-oriented outcome, and it said, in actual fact, almost a third of these patients were unhappy after sling or figure-of-8 treatment, and the non-union rate was much, much higher than what we expected. So this paper opened the door for the fact that maybe these patients aren't doing as well as we thought they were in the past. So around 2005, we knew that closed treatment or non-operative treatment had a significant failure rate. We knew that fixation was fairly simple and had a high success rate, so maybe we should start fixing all clavicle fractures. Before you do that, before you change from treatment A to treatment B, you need to step back and think, are you sure this is the right thing to do? Because whenever you introduce a new treatment, unexpected complications can happen, as we've seen with many things, including metal-on-metal hip replacements, heat shrinkage for shoulder instability, etc. This is a paper written by authors in 1991 looking at early intramedullary nailing, and they said everyone does fine with their shoulder. The same authors wrote a letter back to the editor of the same journal a number of years later saying, when we did that original study, we didn't look at shoulder pain, and we were wrong. It makes people's shoulders very painful. And I don't show this letter to be critical, but to compliment the authors on their honesty and to point out that many times when we introduce new technology, we have unexpected consequences or unintended consequences in that technology. So to truly change from one treatment, a sling, to another treatment, fixation for clavicle fractures, we needed something better, which was a randomized controlled trial. With the Canadian Orthopaedic Trauma Society, which I was with back in the day, we did that study and we randomized 130 patients with clavicle fractures like this to surgery or no surgery in a randomized fashion. And we were fairly liberal about plate fixation, and I don't want to get too technical here, but you had to put a plate on it, reduce it and put a plate on, and that was about all we dictated as part of the study. Interesting, we found that surgeon-based scores were better, so the constant score was better in the shoulder. The operative group was better at all time points, both a clinically relevant and a statistically significant difference in constant scores. The DASH score is a disability score, so a lower score is better. You can also see that patients who are better subjectively in terms of patient-oriented outcome when they had their shoulder fixed. This is something that was important to have reproduced. So there are many studies in orthopedics where one group or one center does a trial and says, this is the best thing ever, but no one else can replicate those results. And those kind of things aren't very useful to us if no one else can do what the original authors said. So since that time, there have been a number of randomized trials. There's about 14 now looking at surgery versus no surgery. And they've all found basically the same things, is that the non-union rate is dramatically lower in the surgical group, and the DASH and constant scores are better, especially early in these studies. We looked at all of these studies together when there were about 6 or 7 of them. We did what's called a meta-analysis, so we joined a number of these studies together, and we saw that what happens when you put all the data together. This study produced a lot of information, and so I'm going to just talk about one specific factor, which is non-union here. And you can see from this forest plot that the clear clear superior treatment is surgery to reduce the non-union rate. So you could argue about, a lot of people do okay without surgery, and that's true, but overall, most patients do better with surgery, and their non-union rate is significantly lower in all of these different randomized studies that were done, especially early. So now, this early fixation has become the standard of care for most professional sports organizations in the world. So in the National Football League or in the Soccer League or in the National Hockey League, if you break your clavicle in general, it gets fixed because it's clear those patients get back to playing much more quickly. Just an example of a hockey player. I know hockey is not a big sport in Brazil, but I couldn't find a soccer player to show, so I'll show hockey. This was an injury that used to would put a player up for the entire season. This particular player had his clavicle fracture fixed. They thought when he first broke it, he was going to be done for the season. He had it fixed, came back to play 6 weeks later. So that's a very rapid response to a high collision type of activity, and this is something that had become standard of care. That year, his team won this trophy here, which is the Stanley Cup. For people like me from Toronto, we haven't seen it in 52 years, but hopefully someday it will come back to our city. So in 2019, we know that fixation reduces the non-union rate, and if you look at the meta-analyses, it's from 20% down to 2%. It reduces symptomatic malunion rate. decreases time to union, improves overall function. It does all these things we talked about here. But all the information that we give you is not to say you go to the patient and tell them you have to have surgery. It now gives you information you can discuss with your patient so you can make an informed decision together based on what the reasonable risks and benefits of surgery are going to be. It's true a lot of patients treated non-operatively do well without fixation. That may be the course you choose with your patient, which is fine. If you fix it, a common reason to have to come back to the surgery is to have the plate taken out, and that's something the patient should know about. So all these studies are trying to basically take a pendulum which has been way too far over on one side and just tease it back into the middle where it should be and not have it swing too widely the other way. So the whole goal of these randomized trials are to give you as the surgeon accurate information that you can use in making a decision with your patient about what's best for their clavicle. And I usually give this information to patients, and I answer the questions, and then we make a decision together, and then I document that carefully in the note. And these studies and other studies like it have changed practice. So in my old province of Ontario, you can see once this study was published, the number of clavicle fractures being fixed went up significantly. And this is important for a number of people to know. People are going to pay for the operations, governments or insurance companies, they should know that. At the same time, there are a number of studies which came out and showed that Achilles tendon repair was, if you used a early functional rehab, surgery and no surgery weren't much different. And so based on those randomized trials, the incidence of Achilles tendon repair has gone down based on modern studies. So you can change practice by doing that. One thing I would mention about clavicle fractures is you need to be careful with the technique you choose. So there are many different techniques out there, and I'm not trying to support one over another, but I will say that use a fixation device which is well supported in the literature for the size and activity level and compliance of your patient. In general, in North America, 3.5 pelvic reconstruction plates are not strong enough, and they have a higher failure rate than pre-contoured plates or compression plates. The problem with compression plates is that they're very bulky and awkward. So in general now, the standard of care in North America has become a pre-contoured plate for the clavicle. A number of different companies make them. They fit the clavicle better, the reoperation rate for removal is lower, and they're strong enough that they don't break. And I think that's probably fair to say it's become the standard of care. Other countries have used small caliber pins, which may or may not be as successful as plates. Certainly for comminuted fractures with multi-fragmentation or unstable fractures, pins don't have as good a track record in North America. The last thing I want to say is that you have to remember that fixing a clavicle fracture is a finesse operation with a narrow risk-benefit ratio. If your patient's older or diabetic or sickly, it's probably not worth it. If the fracture is not badly displaced, leave them alone. It's a very narrow risk-benefit ratio, and I'll demonstrate what I mean by that with this next slide. If you look at risk-benefit ratio for surgery, a femur fracture has a bad prognosis. It can be life-threatening, and so nailing a femur early or fixing a femur early can literally be life-saving in a polytraumatized patient. The non-operative treatment of a femur fracture is terrible. It's traction in bed for 12 weeks. It's awful. We don't like to do it. If you nail a ream lock nail in a femur fracture, is almost indestructible. The patient has a very difficult time ever doing anything bad. They can walk on it right away. Multiple studies clearly show that. If you don't fix it right off the bat, reconstruction is very difficult. So almost every femur fracture we see, older patients, younger patients, high demand, low demand, displaced, undisplaced, femoral shaft fractures get a reamed locked nail almost every time, and that's because it makes sense. Clavicles are different. The benefit is more narrow. It just improves upper extremity function. But non-operative treatment's not terrible. You can put them in a sling, and they'll usually be okay. They may not like it but for a while, but they're still fairly mobile. Anything you fix in the clavicle can fall apart. No matter how good a surgeon you are, any plate you put in there can be broken apart if someone goes back to sports too early or falls down the stairs drunk or whatever. So be very careful about using this kind of device in patients who are substance abusers, etc. The risk-benefit ratio is different. So there, clavicle fractures, you have to think very carefully with your patient whether the benefit is sufficient to warrant the risk. And this slide demonstrates the differences in decision-making between those two different types of procedures. Thank you very much for your attention.